On behalf of Northwestern's Physical Sciences Oncology Center, I'd like to welcome you to the workshop. We're absolutely delighted that we've gotten we're absolutely delighted that we've got such a big turnout. I just want to make sure all of you know Dr. John Whittam, you want to raise your hand. He's the PI of the Physical Sciences Oncology Center, and of course he's very delighted to have you all here as well. And I am Bennett Phillips. I am the co-director of the Education and Training Unit of the Physical Sciences Oncology Center, and this is the unit that actually organized the workshop. So I want to acknowledge the support of Actium Biosystems, and I also want to acknowledge Will Casimir over there, raise your hand, who has taken care of all the logistics for the workshop, and he's done his usual splendid job. So just a few comments about the Physical Sciences Oncology Center. So we're one of 12 centers that was funded by the National Cancer Institute in the fall of 2009 to conduct research that applies the concepts and methodologies from physical sciences and engineering to the study of cancer. All of the research projects in our center and in the other 11 centers are all being carried out by teams comprised of physical scientists, engineers, mathematicians, tumor biologists, and oncologists. The research in our center is primarily focused on the encoding and decoding of information in the genome, genetic information and epigenetic information as it applies to cancer. And all of our research and the team members who are conducting the research are all described on our website, listed over here, psoc.northwestern.edu. We encourage you to visit the website. It contains information about all of our other educational activities, and there's a lot of them, as well as funding opportunities. And you can also access videos of past seminars that the PSOC has sponsored. Okay, so in addition to carrying out the research projects, all of the centers have to have an education and training unit because the NCI is very keen to prepare a new generation of scientists that can work at the intersection of the physical sciences and tumor biology. Now, cancer, as you're going to find out, is a very complex biological phenomenon. And despite the fact that we've had some of the brightest minds in biology and medicine working on cancer for years and years, really the phenomenon is still I wouldn't say poorly understood, but there's a lot still to learn about it. And that's why the NCI is really very excited to have engineers and physical scientists working on the problem and trying to apply kind of new concepts and approaches to examining problems in cancer research. And we feel one of the barriers to attracting physical scientists and engineers to work on cancer is that they kind of view cancer biology as what you call terra incognita, unknown ground. And so the workshop is kind of designed to circumvent this problem by kind of introducing you to some of the terminology, concepts, and methodologies that are used in cancer research. So just a brief overview of the workshop. There's going to be 3 sessions this morning. There's going to be lunch in Silverman Hall. I guess there'll be signs directing you there. And then 3 sessions in the afternoon. Tomorrow morning there are 2 sessions. And we will also be passing out evaluation forms tomorrow for you to fill out. We really need your feedback because this is the first time we're offering the workshop, and we need to know what works and what doesn't work. If you don't plan to be here tomorrow, please fill out the evaluation forms today and give them to one of us at the welcoming desk. We also are strongly encouraging questions either during the sessions or after the sessions. There'll be a Q&A after every session. And there's going to be people passing microphones, so please wait till you get a microphone before you ask the question. Please be aware we're videotaping this. workshop. So, and it's going to be on our website, so you'll be able to access the sessions later at your convenience. And people in the audience may be captured on camera, so you might not want to text if you don't want everybody to see you texting, but whatever. Okay, so I'm going to introduce our first speaker, who is Dr. Jonathan Licht. He is the Senior Scientific Investigator of the Center, and he is also Chief of the Division of Hematology Oncology in the Department of Medicine at the Feinberg School of Medicine. So in addition to his administrative and clinical duties, he also runs a quite large lab devoted to studying transcriptional alterations in hematologic malignancies. So Dr. Licht is going to give us an introduction to basics of clinical oncology. Thanks.
Thank you, Bennett. Great. Well, thanks for everyone for coming here. Good morning. We're very excited by your interest. And my goal here today is to assume that you're all extremely well-trained engineers, chemists, physicists, but may have moderate amount of knowledge about the problem of cancer, both the clinical problem and the basic problem. So my goal here today was to introduce you some concepts, give you a little histology lesson, what do tissues look like, and tell you about a few success stories where innovative scientists and biomedical engineers in terms of processing and making drugs have been successful in using new basic concepts to form new cancer therapies. And I'll finish up by telling you a little bit about, giving you a little bit of overview of what our cancer center means to you, what it means to society, and how clinical research in cancer occurs. So how will we define cancer? We can call it a, is this the pointer? Is this the pointer? Okay. An uncontrolled growth of cells within the body. These cells grow without regards for normal organ boundaries. So we normally have orderly growth of cells that form tissues and organs, but when these things get disorderly, okay, thank you, disorderly, then we can have a cancer. The important salient qualities that will lead to more for sickness and death will be the fact that these cells invade normal tissues and metastasize or spread to parts of the body where they should never occur. A tumor refers to an overgrowth of cells. We talk about tumors being benign or malignant. Benign, you have normal-looking cells, there are just too many. Now, so-called benign tumors can be pretty hazardous if they're in the wrong place. Tumors called meningioma of the brain, of the lining of the brain, are not malignant. They don't metastasize, they don't invade. But because they can occur in a small space in the brain, they can be quite lethal under certain circumstances, even though they're, quote, benign. But malignant tumors that we think about are tumors such as colon cancer, breast cancer, which invade tissues, that destroy normal tissues, and break off and form new sets of cells growing in other organs. Those are called metastases. And that's what we think about when we talk about malignant tumors. So when we talk about types of cancers, we talk about carcinoma. This is defined as tumors of cells lining an organ, an epithelial layer, where there's one side that's facing the blood supply and another side that's facing an open lumen, an open tube, such as the lining of the gut, the lining of the lung. Any tumor of those cells lining an open space is called a carcinoma. Here are the examples. By contrast, sarcomas, which are rare tumors but quite important in young people, are tumors of structural tissues such as bone, cartilage, or muscle, or the lining of muscle. So these types of tumors are more of the things that hold you together. Leukemia and related types of tumors are tumors of blood, commonly of the white blood cells used to fight infection, and we'll show some pictures of that. And lymphoma are tumors of the white cells that produce antibodies. So these are sort of the major subcategories of cancers. This is an example of a normal tissue, and this is an epithelium surrounding a lumen. You see the cells are nice and regular, and here's an open space here. This is a glandular structure. Cells surrounding an open structure and maybe secreting some things here. I don't recall which tissue this is right now. Anyway, but it looks nice and regular. Here's another example here. Here we have all these cells. This is underlying supporting tissues. These things are collagen fibers that help support the tissue. And here we see this area here is called the basement membrane. This is sort of just the substratum upon which cells lay on top of in a nice orderly manner. And what you see here is that these cells all look pretty much the same size, same shape. It's kind of got a beauty to it. Again, here's another glandular tissue where the cells are surrounding a lumen, but they're all pretty regular. They're surrounding supported tissues as well. Again, nice, very. This is skin actually, where the basal layers here is where the skin is. Skin cells are repopulating the skin. Then these cells, as they move up towards the upper layer, they start getting cornified, meaning they get collagen dumped into the cells. And the upper layer of the skin is actually dead skin, the skin that just sort of brushes off when you dandruff or just washing yourself. So basically, this is a constant renewal. Down here, these cells are alive and dividing and repopulating these layers of skin, and this skin is the dead skin, but quite dense in collagen and water impermeable and keeps the germs out. So this is all very orderly. Again, this is a smooth muscle tissue, very regular looking. Okay, you get the idea, right? So it's nice and beautiful. So here's normal breast, and here's a benign breast tumor. This tumor is forming within a lumen, and it looks somewhat disorganized, but it's not quite invasive. It seems to be growing within the lumen of one of these ducts. By contrast, this is a little dark here. It's unfortunate. But over here, we start seeing nests of cells growing within the breast tissue. And over here, we see an infiltration of these cells with very dark nuclei. And that's one thing that our center is studying. Why are these nuclei so dark? What's changed in the chromatin? What's changed in the physical state of that nucleus to cause it to stain deeply with these chemicals? This whole thing started with chemistry. By the way, we didn't know any of this in, let's say, 1860. But when people discovered coal tar dyes, one of the first things they did is they put it onto sections of tissues, and they found, lo and behold, these tissues could be stained. And then you could, instead of looking on a microscope at a clear, translucent piece of tissue, structures would be found. And the first beginnings of pathology and histology were just describing all this, describing this pathology here. So, but what the exact physical basis of this change in color is not completely understood. Here's another example here. Here's a normal esophagus right here, and here's esophageal cancer. You see that there seems to be cells over here that are too dark, and they're mixed in within the tissues. We also see these cells look dark. They look different sizes, different shapes, and they're in the wrong places. So we get a real disorder of the normal growth, and that's what's kind of what you need to know. Now, those are the epithelial tumors, which are the commonest tumors here. And here we have tumors of the bone marrow. This is an aspirate of bone marrow. What we do in the clinic is we take a little needle and, well, it's not so little, but anyway, it's actually generous. And in the rear, in the iliac crest, right back here, we routinely do this. We numb up the bone, go through the bone layer into the bone marrow, and actually, with a syringe, suck out some bone marrow, and then smear it on a slide and stain it with these wonderful dyes. Now, you don't need to be a hematopathologist to say just what you see here are cells of different sizes and different shapes, kind of looking, and the idea here is just like we saw in the skin layer, the very bottom of the skin is the undifferentiated cells. The top of the skin, the cells are forming a differentiation program to form specialized structures. Here we have immature cells with big, big nuclei, very big cells, and more differentiated cells, like this cell over here with a kind of bilobe nucleus. This is a primordial white blood cell that fights infection, a granulocyte. By contrast, this over here, which looks like it's starting to turn pink, is a red blood cell precursor, and there in red are red blood cells. The idea of this is to say that we are seeing every different size and shape of blood cell. This is normal. It says that the blood cells are being born in the bone marrow, dividing, and as they divide, they differentiate and change to form specialized blood structures. This is normal blood production. By contrast, in leukemia, when you do the same aspirate in a person with leukemia, you find that the bone marrow of this normal progression is replaced by a population of cells that all look about the same size and same shape. All these big cells, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. These are blast cells. These are immature immature cells that have formed the ability to self-renew without causing any differentiated progeny to form. So this, again here, these big cells that all look alike are replacing and crowding out these normal blood cells. So these would be an example of leukemia. So what I just try to do right now is to give you a little sense of how, as a clinician, I'm not a pathologist, but I kind of know what regular tissues look like, being drilled in medical school years ago, and I know what disorganized tissues look like. And part of my life as a person who takes care of people with leukemia, I know what normal bone marrow looks like, and I know what leukemia cells look like. We go and we review this with very skilled hematopathologists who spend hours and hours reviewing these slides, and with that pattern recognition, help us make the proper diagnosis so we can treat these patients properly. Okay, so who gets cancer? Unfortunately, about 1 million people per year, and about half of men and a third of women by the time, over the lifespan. But cancer is primarily a tumor of people who are older, 3/4 of cases of people over 55. Here are some statistics of the commonest forms of cancer. The commonest form of cancer among men is prostate cancer. Prostate cancer, if you take a look, if you did autopsies on every person over the age of 90, almost all of these men have little foci of prostate cancer in their prostates. It may not bother them, a stitch in their lives, but it's there. So this is actually something that comes on with aging. So this huge incidence of prostate cancer is not accompanied by your huge mortality. There are deaths and suffering from prostate cancer, but a lot of cases are fairly asymptomatic. By contrast, lung cancer is a scourge. Lung cancer was a reportable disease in the early 19th century or the 17th century, but by the time tobacco took hold, it became a very common disease with somewhere between 150,000 and 200,000 cases a year in the United States. This is a scourge. At one time, I believe 1/3 of the population smoked, I think, or half, and now it's down to about 1/4 and continues to drop. So we're hoping that this will go away. Colon cancer is the third commonest, and this is amongst the reason why there's active screening programs which are suggested as part of health maintenance, that anyone over the age of 50 get colonoscopies every several years. And then we have other tumors going down here. As you can see, the blood tumors like just lymphoma and leukemia are fairly unusual relative to these major solid tumors. In women, the commonest cancers amongst women are breast cancers. Now, you'll see something different in mortality statistics. Unfortunately, with women smoking over the past 50 years, there's been an increase in lung cancer, which hopefully may be abating. And after that, the tumors specific to the female reproductive system are important, and then you similarly have a similar incidence of other types of tumors. If you take a look here at death rates for men, the largest death rate from cancer in this country is from lung cancer, highly preventable with cessation of smoking. That's not to say that lung cancer does not occur in people who don't smoke. There are cases. There's a case, an article in this past week's New Yorker about a very unfortunate young woman who was giving birth to her first child and had lung cancer, never smoked, and talks about her story. So this happens. One of my colleagues has an 18-year-old in Michigan with lung cancer. This happens. It's rare. Don't get scared about it, but it does happen. As you can see here, we saw the huge amount of prostate cancer, but not as much a huge mortality compared to lung cancer. So a lot of people live with cancer, survive cancer, and thrive even with their tumors with proper therapy and management. But some tumors are really quite deadly. Pancreas cancer is a cancer where virtually everyone dies from pancreas cancer. About 5% of patients have effective therapy. In women, what you can see here is the major mortality from cancer has been breast cancer, except about, as you can see here, in the mid-80s, the lines crossed, and lung cancer mortality exceeded breast cancer mortality for women. That looks, fortunately, like it's leveling off, and we hope that'll decline, along with breast cancer mortality, which has definitely declined. Okay. So that's a little bit about the epidemiology of cancer. Now, what causes cancer? Well, we believe it's a genetic disease, that there's damage to genes cause a permanent change in a cell, giving it a growth advantage. So a normal cell transforms into a malignant cell, which then clones itself or makes multiple copies of itself and to form a monoclonal tumor or a monoclonal tumor. So this one cell, a very bad thing happens one day, and this cell gets the ability to self-renew and to crowd out all the other cells. So what causes this? So when we think genetic damage, what is causing the damage? There are different carcinogens we think about. Ultraviolet rays, very preventable. There's 1 million cases of skin cancer per year. This is a huge amount of cancer, actually the commonest form of cancer, but it's very treatable. In this country and in most of the developed world, people rarely die of skin cancer because they're picked up, they're removed. Of typical skin cancer, melanoma, which is a tumor of the pigment-producing cells that cause us to have pigment, those are much more fraught, and there's much more mortality from melanoma because it has a high tendency to metastasize, whereas epithelial skin cancers, what we call squamous cell, like those cells that are going to form the dead skin, they don't tend to metastasize. They can be locally invasive. So these are ultraviolet rays. Environmental, such as X-rays, just living on Earth and being bombarded by cosmic rays from the planet, whatever. Maybe an astronomer can tell me about which planet has John, do you know anything? Never mind. Anyway. Distant, thank you. We're trying to bring in the astronomy too, okay? All right. So the other thing, though, in terms of physical science is radon. Radon in your basement. Radon in just decaying. Living on certain areas where there's a lot of uranium dust. Living in Nevada, where unfortunately the streets are paved with depleted uranium shells, is in certain parts is not such a good thing. So cosmic radiations and natural radiation. Asbestos, which is a strange thing. It's a mineral. It forms long, skinny needles that seem to irritate the body in a very, very noxious way and cause damage. How exactly it causes cancer is a little bit strange to me, but minerals, organic chemicals. Some of you have probably used benzene. I remember using benzene. I remember the Rotovap for the chemists here, and it's got kind of a seductive but dangerous smell. Anyway, infectious agents are not to be underestimated. This was at one time quite a controversial thing, but there are cases of human cancer clearly related to infection and preventable. Papilloma virus, that is a major cause of cervical cancer. This is where, over the past several years, a vaccine, one of them is called Gardasil, not endorsing it, but it's the name of it, that if young women and young men are vaccinated against this particular form of papilloma virus, cervical cancer will largely drop and disappear from this country. Hepatitis virus, the commonest cancer in the world is hepatoma, or liver cancer. That's because 500 million people in the planet or more are chronically infected with hepatitis B virus. And this chronic infection causes a regenerative response in the liver, which sends up a fertile ground for cancer to occur. Bacterial infection, it turns out that that a lot of ulcers, everyone talked for many years that peptic ulcer disease was due to too much stomach acid. It turned out it was always due to the infection with a particular bacteria. And it took a crazy gastroenterologist in Australia who actually swallowed an aliquot of the bacteria and gave himself an ulcer to prove this, and then cured it by taking the right antibiotics. But peptic ulcer disease, it can also be, and these bacterial infections are associated with stomach cancers. So these are things here. And we can't, this should be iatrogenic. We have to think about iatrogenic forms of cancer, which is cancer chemotherapy, which we'll discuss can actually cause cancer. Radiation therapy. There's now concern about too many CAT scans being done. CAT scans are sort of like getting 50 chest x-rays at once. They should be used sparingly because they give the body radiation, and that may cause, at some finite rate, cancers. Immune suppression. We now have an explosion of organ transplantation. Heart, lung, liver. Northwestern, our school downtown, is one of the major centers in the world for liver transplantation, kidney transplantation. When you suppress the immune system, you get increased incidences of cancer. So here's, this is some of the hallmarks. Our next lecture, we'll talk about this some more. I'll go over briefly. We could say that cancer, this is a pivotal article about a decade ago from Doug Hanahan and Bob Weinberg about what are the important characteristics of cancer that makes it cancer. And we can say here, we have several things here. Self-sufficiency and growth signals. These things don't need an external clue to grow. They're insensitive to anti-growth signals. They invade and metastasize. They replicate forever. They make their own blood vessels to feed themselves, and they evade programmed cell death or apoptosis. So normally there are on the cell surface of cells growth factor receptors that respond to growth factors. Sometimes these cells produce their own growth factors in sort of a do loop of turning themselves on. Does that sound familiar? Do loop? Okay, good. All right. Okay. But sometimes there can be another module of code will tell them to signal as well. So you can have cross-regulatory reactions as well. So you do have growth factors, but cancer cells seem to signal without needing this growth factor and receptor signaling. Cancer cells overgrow. When you take normal cells and put them in a petri dish, they fill up the dish and then just sit there and do nothing. By contrast, cancer cells grow and grow on top of each other and form these, overgrowth structures. So normal cells, just like normal tissues, know where they should be and they know where they shouldn't be. Cancer cells ignore that and grow where they shouldn't go. And cancer cells invade. This was the basement membrane that I showed you in those histology slides. A tumor will invade and actually actively secrete enzymes that dissolve the collagen and allow the tumor to go and invade tissues, blood vessels, and other structures. Cancer cells are immortal. If I take a bit of your skin cell, Lou, we'll take some of your skin cells, we put them in culture, and we say we're going to take some of his skin cells and we're going to grow a petri dish full of them. And then we're going to take those cells and we're going to scrape them off the plate, dilute them maybe threefold, and grow them again. And just repeat and repeat and repeat. And if we count the cumulative cell number over time, what we'll find is that the cells will increase in number, and then each time we dilute the cells, we'll get fewer and fewer cells back. The cells seem to run out of steam. They have a finite lifespan, and then you actually start getting fewer cells as you do your dilution of the cells in the petri dish. Okay, this says that cells have a finite lifespan. By contrast, a cancer cell, and there's a new popular book called about Henrietta Lacks, the life of Henrietta Lacks, who was a patient with cervical cancer, I believe at Johns Hopkins, and her cells were taken from her tumor and put into culture, and we use them 60 years later today. So Henrietta Lacks' cells are alive 60 years later. Although Henrietta Lacks is not. So this cell is, if handled properly, this cell will be alive hundreds of years from now too. So these cells are essentially immortal, whereas normal cells of your body are not immortal. Any tissue needs a blood supply to bring nutrients and oxygen. And what actually tumors do is secrete growth factors to stimulate the ingrowth of blood vessels into the tumor to help them grow. And cancer cells escape cell death, and I'll show you a movie of that in a few minutes here. There's a stereotypical program that every cell in the body has to kill itself. And this program is called apoptosis. Apoptosis is what makes us have no web between our fingers. When we're tiny embryos, we have a web between our fingers, and these cells are then programmed to die in a stereotypical way, not in a messy way, not like getting a burn or having a cut or an open wound, where cells are dying by what we call necrosis. But they die by apoptosis, which is clean, neat, and marks the dead cell to be removed by special cells in the cell that actually act as garbage collectors. So this is a neat way of trimming off the excess fat, if you would, from the body. So when we think about cancer being a genetic disease, we're not always saying that it's an inherited genetic disease. So there are two possibilities, though, that if you have a mutation in a parent in the egg or the sperm, the child will inherit this, and every cell in the body will have the mutation. So these are hereditofamilial types of mutations. So we'll call these germline, meaning the germline mean the eggs and the sperm are the germline mutations. By contrast, other types of mutations are somatic mutations, meaning only some cells in the body have it. They were acquired after conception and after birth. These are called somatic mutations. So cancers can be associated both with hereditofamilial mutations as well as somatic mutations. So when we say we have genes involved in cancer causation, there are two major classes of genes we talk about. One are called oncogenes. These are genes that normally regulate cell growth in an organized manner. But when these genes are mutated, these genes essentially take these enzymes and make them hyperfunctioning. They're working too well. They're not responding to negative regulatory clues, and they actually are essentially speeding up the car in this metaphor right here. That's one class of cancer-causing gene. And the other class are tumor suppressor genes. Now, there's implications of this. When you have an oncogene, remember we have pairs of chromosomes, and we have two copies of most of the genes, except on the not every gene is duplicated on the X and the Y chromosomes. So some genes are only on the X, and we only have one copy. But every other gene on chromosome 1 or 2, we have two copies of the gene. But in an oncogene, only one gene has to be mutated, and only one half of the enzymes, for example, have to be hyperactivated to stimulate the cancer. So one hit is required, we say. By contrast, tumor suppressor genes are genes whose normal function is to put the brakes on cell growth, preventing cancer. So what actually happens is someone can be born with a inherited mutation in the first tumor suppressor gene. So they don't have a cancer, but they have a tendency to get cancer because all they need to get the cancer is to get a second mutation or a loss of a chromosome segment, which can occur in somatic cells, and then all the brakes are off and the car goes ahead. So you've heard of familial breast cancer, for example, which occurs in about 5%, 3% of breast cancer is hereditary in nature. Women are born with an inherited tendency to get breast cancer because one of their breast cancer preventing genes is mutated at birth. To get the breast cancer, instead of needing both genes to be mutated, which are two rare events, only one gene has to be mutated, which is much more likely to happen during someone's lifetime. So women with hereditofamilial breast cancer will tend to get breast cancer at, instead of the age of 60 or 70, maybe the age of 30 or 40. And they will often get breast cancers, multiple breast cancers, in both breasts, because the entire breast tissue is at risk, because every breast cell is missing one gene. And any of those cells needs to do is get one more mutation, and it'll turn into a breast cancer. That's why you've heard of women with this familial tendency of getting preventative mastectomies followed by breast reconstruction. Often recommended. A harrowing decision, but often this risk is managed this way. Now, the third type of gene that occurs that's mutated in breast cancer are DNA damage response genes. We have an entire machinery that protects our genomes from repeated genetic damage. And we have a safety system, if you were. If that safety is put off, then our cells can accumulate genetic damage, some of those in oncogenes, some of those in tumor suppressor genes, and we can get a cancer. But it's not that these genes themselves, these proteins, actually control cell growth. They prevent DNA damage from accumulating. So that's a third type of gene that's associated with a predisposition. And these are examples of some carcinogens which damage and mutate DNA. These include metals, small molecules, aromatic compounds, aflatoxin. This is a toxin that's made in a mold that grows on moldy peanuts. And it tends to occur where crop storage conditions are not optimal. So we can think about carcinogens occurring in the natural world. This was not created by Monsanto or DuPont. This was created by the evil fungus. So it's not just a corporate malfeasance. Anyway. Okay, so when we say that cancer occurs as a genetic disease, these mutations accumulate over time. It's not like, it generally doesn't happen that you get one mutation and poof, you got a cancer. But cancer takes years to develop. Now with the technology such as we're exploring in this PSOC Center of being able to resequence the human genome and resequence every snippet of DNA from a tumor, there are estimates that any given tumor might have 25 to 40 or 50 different point mutations or deletions or insertions of genes. Whether or not all 25 are causative is not yet clear, but any given cancer may have a half dozen or more genes that are mutated, that each one of which plays a role in the development of that full-fledged tumor. Now, when you think about how a colon cancer develops, the colon cancer develops first when you have a nice flat piece of colon, and then some cells start to grow and form a little bump on the colon. Then they sort of grow as a stalk, like it's called a polyp. Then that polyp gets bigger and bigger, and finally this polyp starts to grow and invade below that basement membrane and cause metastases. Now, because colonoscopy is a frequent procedure and there's a lot of specimens obtained, scientists were able to get very early polyps where there's just a bump over the colon, polyps on a stalk, polyps that are so big that they don't move anymore, and invasive cancers, and enumerate what mutations are going on. And what they find is that the normal tissue, there's no mutations. A small benign polyp, there's a loss of a chromosomal segment called the APC gene. A benign polyp starts to get a RAS mutation. RAS is a signaling molecule that causes cell autonomous signaling. Then over here, you start getting an invasive cancer, and you start losing the gene called P53, which is a very important gene in controlling cell cycle and DNA damage. And you lose other things. So you go from having one to the APC. Now you have APC and RAS. Now you have APC, RAS, P53, APC, RAS, P53, and DCC, and so forth and so on. So this takes years to develop. And there's accumulation mutations before this tumor evolves from normal tissue to frankly metastatic disease. So it's not just one mutation, but an accumulation of mutations over time. So how can we just as very educated scientists and students, how do we prevent cancer? No tobacco, no tobacco, no tobacco. Limited alcohol, of course, I strongly encourage Friday afternoon happy hours in accordance with university policies, but in moderation. Okay. Lower fat diet, more fruits and vegetables. These are all, These are all things to do. Avoid occupational exposures. There's massive campaigns, particularly in Australia, where the melanoma rate's going through the roof for kids to wear hats. I just even think my own kids. I never wore a hat going outside. Everyone wears a baseball cap now. You should be wearing these more like cricket hats that shield your neck too. My son has one. Anyway, and vaccination of these against hepatitis. We should have universal vaccination for hepatitis and papillomavirus. And the other thing is screening. The multi-step nature of cancer means that early detection finds smaller, less aggressive tumors that can be cured. And the best therapy for cancer of that type is cut it out with a scalpel. That's the best cure. So let's talk about cancer therapy and some milestones. So one milestone was being able to knock people out for surgery. The ether dome in Mass General was one such place where they dripped ether, an organic chemical, right, and put people out under anesthesia and were able to do long, complicated operations to remove tumors. So this was a major milestone in cancer therapy because if those people who are cured of breast cancer, cured of lung cancer, cured of colon cancer have surgical cures. And the idea is, screen, find early tumors, take them out surgically. That's the best way to do it. Now, in the 1890s, you had Marie Curie and her husband start understanding radiation, and then we started radium therapy of skin cancer. So this was where you were for about 40 years until the 1940s, where a group of sailors were handling some mustard gas, I guess, left over from World War I. The mustard gas leaked. These sailors got very sick. And at this time, we started having automatic blood counting machines. So white blood cells, red blood cells, the blood clotting cells called platelets could be counted. And it was noted that these sailors had a profound drop of their lymphocytes, their antibody-producing white blood cells. And this led to the notion, well, if this is a mustard gas can remove lymphocytes, maybe we can liquefy the mustard gas and we could use it to treat lymphoma. And this led to basically mustard was for many years a mainstay therapy for Hodgkin's lymphoma and non-Hodgkin's lymphoma. And that's how it came about, from a military accident. In the 1960s, better understanding of radiation, cobalt and high-energy X-rays for internal treatment of tumors. And this has gotten very sophisticated, and a lot of physicists are involved down in our Northwestern campus. There's a lot of interest. The University of Chicago's got a huge center. The Argonne labs are involved. How to best use radiation in shaped beams and sort of three-dimensional beams where you overlap the beams so you get the maximum amount of radiation right to the tumor, sparing normal tissues. So this is a very sophisticated undertaking, and there's a whole cadre of clinical physicists who associate physicians, who assist physicians in planning such therapy. In the 1960s, the idea came up where, well, we have mustard, we have a few other agents that seem to kill tumors. What if we combine these agents together to form multi-agent combinations? And this was found to basically lead to the cure of childhood leukemia. You could get temporary remissions or abatement of disease with one drug, but if you added 2, 3, or 4 drugs together, you could actually cure childhood leukemia. So, how does chemotherapy and radiation therapy work? Well, it works, ironically, by damaging DNA. Normal cells cease growth and repair damage, but many cancer cells can't repair the damage, and the cell suicide program is triggered. Let me get my... Let's see. Let's see if this movie's going to work here. So this is a movie from my friend Doug Green. Can we turn the lights down a bit? Can we turn the lights down? Is there a way to do that? These are cells growing happily in culture, and then they're treated with an agent that will cause apoptosis. What you start to see at the red arrows is a cell that sort of shrivels up and falls upon itself and starts forming a bleb-like structure right here. You see that blebbing right there? So that is basically apoptosis. That's what we try to stimulate when we give any kind of chemotherapy or radiation therapy. We try to stimulate or trick this cancer cell into killing itself. Let's see if we have anything more here of interest. So a little bit of a primer here about cancer, conventional cancer pharmacology. We have ideas on how these drugs work, how they can damage DNA, how they might affect different aspects of cell metabolism. But the unfortunate fact is how we use them is largely empirical. It's a huge trial and error process, and many drugs that are designed to work just this way turn out to work, but for a different reason. This is where empirical clinical trials, observational trials, where patients are given drugs, we monitor side effects, we monitor clinical response, is absolutely essential. This is an important set of science as the science that you're doing in your laboratories. As we said here, many of these agents are genotoxic. Others interfere with metabolism of DNA or RNA synthesis. They might deplete a DNA precursor, starving the cell of an essential component for replication. Others actually interfere with mitosis by physically binding to the apparatus that pulls chromosomes apart when cells divide. I think what we'll do here, one thing to say here, this was a very influential article for me early in my training. This sort of notion that cancers are programmed to grow, but they're fragile. They actually can be tricked into dying more easily. On the right, you see a normal fibroblast. I've sort of simulated the growth in very low amount of calf serum. We grow cells, for those of you who are physical scientists, we grow cells in salts and sugar and amino acids, and also some growth factors that we just take from calf serum. So usually these cells grow in 1/10 calf serum. But you can sort of make these cells slow down and grow by putting them in 0.5% calf serum, 1 part in 20, 1 part in 200. Here's 1 part in 100, 1% calf serum, they grow but not as well. 10% calf serum, they grow very well. So these are normal cells. Now what we find with fibroblasts with activated MYC, these cells grow very well in 10% or 1% calf serum, but if you go below a certain level of nutrients, they actually start to die. So this was an observation nearly 20 years ago, and gives you the idea that this cell was, the only difference between this fibroblast and the one on the right is a oncogene called MYC is inserted into these fibroblasts, which makes them grow better under low calf serum, but at very low calf serum, they actually crash. So this says to me that the cancer cell's got a proliferative thrust, but it also could be tricked into killing itself. Now, one thing that's really important is the gene P53. P53 is a responder to DNA damage and causes cells to either stop growing or to kill themselves in response to DNA damage. And I've simulated some of the work done about 15 years ago, where tumors were made in P53 animals where there's no P53 gene in mice. These mice are given some chemotherapy. The tumors take a little dip, but keep on growing. By contrast, animals that have P53 gene intact, they will respond to the chemotherapy, though it turns out that there's some selection and resistance, they start growing back. But there's at least a transient response. So P53 status, whether or not your P53 is mutated or not, helps determine in many cases if your tumor is going to respond to chemotherapy. Childhood leukemia turns out to be P53 is normally not mutated. Other very chemotherapy curable tumors, such as testicular cancer, which Lance Armstrong had, for example, a Wilms tumor, a pediatric kidney cancer, highly curable with chemotherapy, tend not to have P53 mutations. Adult tumors very often have problems with P53 or other aspects of the P53 pathway, and they tend to be more chemotherapy resistant. So P53 works in response to DNA damage. P53 levels rise and turn on an inhibitor of the cell cycle, which tends to stop the cells before they enter the S phase, before they synthesize DNA. And this allows the cell to pause and repair the DNA damage. If you get too much DNA damage. P53 is superinduced, and it tends to induce programmed cell death through the mitochondria. As I said here, P53 tumors are generally more chemotherapy sensitive. When I say the mitochondria is a lot of our cell life death decisions in the cell are made at the level of the mitochondria. Whether the mitochondria is, of course, makes energy for the cell, makes ATP from fatty acids and sugars, and this metabolism, but as well, it's got a program within it that if the cell is sufficiently stimulated, the mitochondria will discharge cytochromes that are used also for the ATP production into the cytoplasm and stimulate a whole programmed cell death pathway. So whether or not a cell will live or die depends upon how happy that mitochondria is. And when we give chemotherapy, when we give certain other types of growth factors, we can change the balance to helping the mitochondria stay happy or be very unhappy. And that's part of what we're trying to do with modern therapeutic advances. This is a little kind of an ancient slide, but the basic idea here I want to show you is here we have precursors of DNA, purines and pyrimidines. These are forming nucleic acids, DNA. DNA is formed into RNA, into protein. All you need to take home here is there are chemotherapeutic drugs in clinical use that interfere with the formation of purines and pyrimidines, their incorporation to DNA. You can damage the DNA by causing chemical cross-linking or strand breaks. We can have agents that prohibit the transcription of DNA into RNA. We then have certain chemotherapeutics that affect proteins. Interesting, L-asparaginase. Turns out that childhood leukemia cells need the amino acid asparagine. How do you treat these childhood leukemias? You actually put an enzyme into the kid's blood that depletes asparagine from the blood supply, and those leukemia cells that really need that asparagine selectively die. So that's not even a DNA damage at all. That's a metabolic therapy. Other types of therapies involve drugs that interfere with the mitotic spindle, which allows cancer cells to pull apart. And these seem to selectively kill cancer cells. Where those drugs came from? They came from plants. They were natural toxins evolved by plants to avoid animals eating the plants too much. So there's a whole panoply of ways that you can use cancer chemotherapy. But the hazard of this is there's a narrow therapeutic window for these cancer chemotherapy and radiation therapy. The difference between an effective dose and a lethal dose might only be a factor of 2 or 3. Now, you could take 2 Tylenol or you could take 6 Tylenol and you're not going to die. But if you take 3 times the dose of a chemotherapy, you could die. So that's why in our practice we have an intensive training program for our trainees in how to use chemotherapy and lots of safety checks on making sure the dosing is right. When we write an order, my trainee writes the order, I reread the order, the pharmacist checks the order, another pharmacist checks the order. This is serious stuff. Okay, so further on in our milestones in cancer therapy, that idea of multi-agent chemotherapy for leukemia was transited to solid tumors of adults, such as lymphoma, breast cancer, testicular cancer, and very often this is trial and error. We were not exactly knowing what target we're hitting, how this was working, but by adding these drugs together in tolerable combinations, we were increasing cure rates. In the 1980s, bone marrow transplantation became a popular modality for blood tumors as well as solid tumors. Now, this had a vogue for solid tumors, meaning a solid tumor meaning not a leukemia or lymphoma, a breast cancer, things like that. There was a vogue for it. The notion was you give people such high doses of chemotherapy, it'd be like taking a walk into Chernobyl. You basically give the body a lethal dose of chemotherapy that would kill the normal bone marrow cells. You wouldn't make any more blood. You would die without any blood. So therefore, you took out the patient's bone marrow before giving this lethal treatment, store it in the freezer, and after they get the lethal doses of chemotherapy, give back the bone marrow. Just as an intravenous infusion, it homes into the bone marrow, repopulates the bone marrow, grow back blood cells, and the patient can survive this near lethal dose of chemotherapy. This clearly works for leukemia, lymphoma, multiple myeloma, blood tumors, and probably didn't really, it may have a modest effect in solid tumors. It's no longer done for breast cancer. It was really big in the mid-90s for breast cancer. But we do 300 of these bone marrow transplants per year for blood diseases downtown. So in the 90s and the zeros, we have new therapies based on the genetics of cancer, which I'd like to talk to you about. 3 different case studies of how a better understanding of the molecular biology of cancer has actually led to major therapeutic advances. The first case is chronic myelogenous leukemia. Now, you guys are now experts. You saw a bone marrow smear, and you can see that these, there's a lot of cells in this bone marrow smear. They're all different sizes and shapes. Okay? This is not normal, but it's not acute leukemia. Acute leukemia refers to the fact that every cell looks the same. This is called a chronic myelogenous leukemia. This is an overproduction of white blood cells due to a signaling defect I'll describe, but you have these early blast cells, and then you have these polymorphonucleoleucocytes, granulocytes they're called, and you see all different sizes and shapes. But these patients can show up on your doorstep with a white blood cell count of 100,000. Normal white blood count is about 10,000, 7,000. But you take a look in the blood smear of these patients, you'll see all these different sizes and shapes of cells. So there's too many blood cells. They're working generally okay. They're not malfunctioning. There's just too many of them. In the past, within several years of diagnosis, this disease would transform into lethal acute leukemia, where, again, all these cells would look the same. They would crowd out the bone marrow. They would invade tissues, and they would cause death. And this form of leukemia that formed after the chronic phase was virtually untreatable. Conventional chemotherapy had not done anything for this disease at all for decades. So the history of this, and someone should get a Nobel Prize for these discoveries soon, I hope, was Peter Knoll in 1961 discovered an abnormal chromosome in a patient with this disease. So these are chromosome spreads. What you do is you take cells from the bone marrow, you grow them in culture, and you basically capture cells in the act of undergoing cell division and metaphase. And these are the duplicated condensed chromosomes. You take pictures. It used to be that you actually took pictures and then cut and paste them into a nice row. Now there's Photoshop software that literally almost does this automatically. There's software that recognizes the size and shape of these chromosomes and lines up this chromosome profile. But this chromosome was abnormal, and it turned out to be a translocation of genetic material between chromosome 9 and 22. Actually, the chromosome broke, and part of that chromosome joined chromosome 9, and part of 9 went to 22. So we call this a translocation genetic material. This was called the Philadelphia chromosome because it was discovered by Peter Knoll in Philadelphia in 1961. So it turned out that when you look at this at the molecular level, in 1985, several groups actually cloned the gene that was at this breakpoint region, and they found a gene called BCR, just stands for breakpoint cluster region, and ABLE. And ABLE was known to be a gene that could actually cause cancer in animals if it was inserted into an animal cell. So ABLE was a known cancer-causing gene. It's a signaling molecule. It's an enzyme that phosphorylates other proteins, adding a phosphate group to the amino acid tyrosine. So what happens when you get BCR and ABLE joined together by this chromosome translocation is you get a fusion protein fusing BCR and ABLE together, yielding a new protein not normally made in the cell at all. So a couple of really novel concepts. First of all, chromosomes are shuffled in cancer. Started by Peter Knoll. Janet Rowley, our colleague at University of Chicago, has done major work on this as well. Next thing, these shuffled chromosomes form a shuffled gene that forms a shuffled protein that normally never occurs in a cell. Next, this shuffled protein is functional. Normally, we have signal transduction from receptors, growth factors. Growth factors will normally signal to ABLE. ABLE will cause a chemical signal in the form of a tyrosine phosphorylation to signal this nucleus signal to the cell nucleus to divide. BCR-ABLE it's always giving a signal, even without a growth factor telling it to do so. So it's always on. It's always telling the cell to divide, and you get abnormal cell division. And this is why you get the phenotype in the patient. Too many white blood cells. They kind of look like the right type of cells, but just too many of them. So can this protein be targeted in a chemical way? And it turned out that people at what's now known as Novartis and Brian Drucker, who was studying the ABL protein, discovered that a drug called imatinib mesylate could exactly fit in. This is the crystal structure of ABL and its catalytic site. And imatinib mesylate actually mimics ATP, which is going to donate a phosphate group to the tyrosine. It fits into this groove and blocks this kinase activity. So the pivotal article nearly 10 years ago, imatinib mesylate was used to treat 58 patients with that chronic phase, and 60% responded. These patients were 58 in the CML phase, CML in the acute phase. They actually went to acute leukemia. And as I told you, and I've treated these patients, they don't respond to anything. 60% responded, as opposed to the expected historical rate would have been 0%. This is remarkable. Then, if you take a look at a patient who shows up on your doorstep with CML and their mortality rate, it used to be that about half of people would die within 3 years. And this curve has even gotten flatter as I've seen more recent one. Now the expected 50% survival rate of these patients is, we don't know, 10 years, 20 years. I have a young woman who was a grad student with a friend of mine in Montreal, first woman in Canada to ever get this drug. She had CML like at the age of 23. I think she's 33 now. She's doing fine. The only hazards these people worry about is, well, they're doing so well, and people want to have kids. Can they go off the drug for a while to have their kids? So this is the kind of problems, the good, bad problems people are having. This was a lethal disease that's now a controllable disease due to this understanding of the molecular genetics. Case 2 is breast cancer. These are some more things. This is a mammogram. This is a breast cancer caught on mammogram. You can see this almost scar-like appearance. It looks like the tissue is being retracted in, and you have this dense abnormal tissue here. This is a breast tumor. This is the histology. You can see these cells are sort of scattering through the stroma here and in an abnormal way. So turns out that about a third of breast cancers overexpress a protein called HER2, which is a growth factor receptor. And they often have a chromosomal amplification of HER2, which can be discovered on this type of assay where you actually take a fluorescent probe to detect extra copies of the gene in the DNA. This is called fluorescence in situ. So this is a negative prognostic marker. So if these patients have that HER2 positive breast cancer, we expect them to do poorly. Now, HER2 is an oncogene in breast cancer. Because of its high level of expression, it actually tends to signal from the growth factor to the protein called RAS into the nucleus, causing the cell to divide. Shown here in artist conception from some drug company propaganda, but it looks cool. Anyway. So anyway, how can you target this? Now, it turned out that there are monoclonal antibodies that will specifically recognize the HER2 protein. And some of these antibodies, this is basically an antibody structure. This is the constant region. These are the variable regions seen here. And the antibody against HER2 tends to shut off that chemical signal and have a therapeutic effect. So the idea here is that trastuzumab, which is the generic name of the antibody known as Herceptin as a trade name, can turn off this chemical signal and stop the cell from dividing. So the first article, again, was nearly 10 years ago. Now, look kind of modest. This was a patient who had advanced breast cancer, meaning they had metastases to bone marrow, to liver, to some other part. And you took all comers and treated with chemotherapy alone and look at their progression-free survival, meaning how long was it before their tumor started to grow once again. You found chemotherapy alone, the progression-free survival, 50% progressed at 5 months. With chemotherapy plus trastuzumab, there was a statistically significant change where there seemed to be 2 months more before the tumor progressed. Well, that's statistically significant. Is it clinically significant? Well, for these patients, and realize there's a tail here where, look at this, 20% of patients seem to be doing very well at 20 months. For those 20% of patients, this is very important type of therapy. But here is a study that actually one of my colleagues who's a breast medical oncologist said when this was presented, there were tears in the eyes of the oncologists in the audience, and there was a standing ovation. This is an adjuvant study, post-surgical study, saying, can we give trastuzumab to women with HER2-positive breast cancer after their surgery in the attempt to eradicate any residual cells, preventing tumor from recurring? So here's what happened in the control. The survival here at 5 years was 67% survival, meaning 1/3 of patients' disease-free survival, and the overall survival was 85%. So people recur from breast cancer a lot more frequently than they die of it, but let's say recurrence is a really bad thing. In 5 years, 1/3 of these women recurred. When they were given trastuzumab plus chemotherapy, they only 15% had recurred. In decades of clinical work in breast cancer, no one had seen that kind of clinical response before, and that's why the kudos were given about 5 years ago. This is now a routine therapy that's given to the appropriate women post-surgery to prevent the recurrence of their breast cancer, and it is saving lives. Yes, sir? No, these regimes are done for a period of time generally. There's chemotherapy and the trastuzumab for around 6 months. So it's a pulsatile thing. The idea is that you render the patient disease-free surgically, but there may be some cells lurking, either at the tumor bed, where you actually treat with local radiation, or circulating, they got out of the field of view of the surgeon. We want to kill them all dead. And it seems that this idea is working. Now, the third case is a novel case that was championed by the late Judah Folkman, who passed away about 2 years ago. The idea that tumors feed themselves with blood vessels, and can we actually not attack the tumor, but actually attack the blood vessels? And the idea here is that there's an antibody called bevacizumab, which is an antibody to the growth factor called vascular endothelial growth factor. And it turns out that if you give this drug with chemotherapy in colon cancer, whereas the median survival of patients with advanced colon cancer, median means half the patients die at this point, was 6 months. Now the median survival is over 2 years. Huge difference. That's a huge difference just thinking about that. So bevacizumab is a huge new advance in certain tumors. Kind of controversial. It was just found to be inactive in breast cancer, made the news last week. It was approved by the FDA for breast cancer. Follow-up clinical trials showed didn't work. So the question is it going to be withdrawn? A month of this therapy is, I think, $20,000. It's very expensive. Okay. So let's just talk a little bit about structure here. Who develops these therapies? We do, right? Our ideas. We're going to get some good ideas, and we're going to do it. But we need help. We have government. The NCI has a drug development program. Academia, Dr. Silverman, discovered Lyrica. Industry, huge programs in drug discovery and basic science. The National Cancer Institute in Washington and our cancer center here. So here's just a little bit of context. I want to give you not just clinical oncology, but what's this context we're working in? In 1930s, the National Cancer Institute was founded. In 1961, the first cancer research facility in Bethesda. The first cancer center in the country was the Fox Chase Cancer Center in Philadelphia. In 1971, Nixon declares the war on cancer, the National Cancer Act. This makes the National Cancer Institute director, who's now Harold Varmus, unique amongst the only he and the NIH director are presidential appointments. The head of National Heart, Lung, and Blood is appointed by the head of the National Institutes of Health. But the Cancer Center director and the NIH director are presidential appointees that have to be confirmed by the Senate. In 1971, there were 15 NCI-designated cancer centers. by 2006, and this is a little bit updated, we're about 41 clinical and cancer research centers, and the NCI budget is $4 billion or 1 month in Iraq. So what is a comprehensive cancer center? We have expertise. Many of you are members of the Cancer Center. Maybe some of you will want to become members of the Cancer Center if you're not already. We have to span many topics. We are interested in cancer prevention and control, epidemiology, outreach, getting the right therapies to the right populations, cancer diagnosis, cancer therapy. We also have to move the field forward with research. We have multi-investigator teams. Some of them are organ site-based. We have a group that's studying leukemia and blood disorders. That's a lot of the people on our floor. We have some people from our floor. We're very interested in leukemia and blood disorders. Others in breast cancer. And then we have 2 unique centers at our center, which is the PSOC, which we're talking about today, where we're trying to take people who think about quantum physics and things like that, and see if they have ideas that we haven't thought about as clinicians or cancer biologists. And we have the Nanotechnology Center in Cancer, where we ask whether or not special chemical materials can offer new modalities for cancer therapy. So what types of research? Of course, we have basic epidemiology, risk factors for cancer, translational. Translational research is sort of like good art. You see it when you know it when you see it, but sometimes hard to define. We just have a paper, I'm checking the galley proofs, where we took patient specimens from 9 patients with a rare disorder, polycythemia vera, and we did gene expression profiling gene expression, compared it to a model cell system we did, and this is now published in the journal Clinical Cancer Research, which I help edit. It's not really a clinical journal. It's really about working with clinical specimens or treating patients with tumors and sampling the tumors and understanding what you did. It's not about we gave 10 people these drugs and 2 responded and 2 didn't or so forth. That's really translational research, an idea of it. And clinical research is really that empirical drug trial. Either I come up with a good idea of how to use Lyrica to cure cancer, or the drug company comes to me and says, we think Lyrica can cure cancer. You have the patients. Let's work together and see if it's true. So clinical trials involve people, and they test new treatments to determine whether they're safe. Most number 1 is safety. Next, are they effective, and are they better than standard therapy? We're unique amongst many countries of the world. Some have this rule, some don't. A lot of countries you can market a drug if it's safe, but it doesn't have to be effective. We require that the drug is safe and effective. Okay? So the idea of a clinical trial is to answer a medical question in a structured manner, and these trials can evaluate prevention, diagnosis, treatment, or quality of life. The important thing for you to know as physical scientists, and I hope never need to do this, but family members may, or someone you know may need to go on a clinical trial. There's some basic tenets here. One is patient safety and beneficence. Patients must understand why they're being offered to participate in a clinical trial. A lot of these trials offer a structured way to offer cancer therapy. They may or may not help that individual patient. You just don't know until you try. The patients are told potential benefits and risks, and it's an ongoing consent, it's an ongoing process. People can withdraw from a clinical trial at any time without any coercion and get just as good medical care. This is what's essential about the idea. These were laws that were put into place after Nuremberg, and a certain code was put into place to prevent adverse evil medical experimentation. Participation is voluntary. You can leave at any time. And there's safeguards to be sure there's patient safety. We have an institutional review board that reviews things here in Evanston and reviews things down in Chicago. We have oversight by the FDA, the NIH, and other agencies. What types of clinical trials occur? The first trial is called a phase 1 trial. You've just taken the trial. You can show that you can give it to a dog and to a rat, and it doesn't kill them. You have an idea of what kind of dose might be effective for a tumor, but it's never been given to a patient before. So that first patient gets a very, very low dose, and it may or may not be effective. What was remarkable about the CML trials is even the very lowest dose in the first patient, a response was seen. That's how good and effective and targeted that therapy is. But very often it takes a number of patients and dose escalation before you find any dose that might be useful in therapy. After phase 1, we know the dose, we know it's safe. Phase 2 says we're going to see if this drug is useful in people with breast cancer or colon cancer or lung cancer. And so you take a cohort of about 15 patients, you treat them all in a uniform manner and ask, did it work or not? And phase 3 compares a promising new treatment to the industry standard. Let's say we have drug A and B or A, B, and C, which is better? Those are phase 3 trials. This requires hundreds of subjects throughout many institutions, and we have a multi-institutional trial mechanism for that. So basically, at our cancer center, you can click on a body part and you can find what kinds of clinical trials are available for patients. And this is a resource available to physicians and patients alike. So in summary, I know I covered a lot, but I hope I gave you a sense. What I hope to tell you about is a little bit of the architecture of the normal tissues, what cancer is, what are the common forms of cancer, what causes cancers, what are the genetic basis, how we treat cancer, what's the basis of chemotherapy, and some real success stories from investigation, from understanding the genetics of cancer has actually led to new and highly effective therapies. Lastly, I told you about the structure in which these basic discoveries may be translated into clinical research and clinical therapies. Thanks. I know we ran over. I think this is an important introduction. I think we have a few questions. John.
I was wondering if you could tell us a little bit about how viral infections can lead to genetic changes that cause cancers to occur.
Well, in the case of papillomavirus, it seems that the papillomavirus, in order to promote its own proliferation, actually gets rid of p53. So these cells are rendered p53-less, so that these cells proliferate unabatedly. They can accumulate genetic damage without properly repairing, and they can go from a chronic stimulated state of proliferation along with the virus to a viral independent state of proliferation. So that's one way that HPV does it. Hepatitis B, I don't think it's anywhere as well understood, but any kind of chronic inflammatory process that stimulates aberrant cell proliferation, you're just even having more divisions, more chances for things to go wrong. So that's a little bit of hand-waving. With HPV, it's clearly known that there's one particularly noxious protein in the virus that actually its job is to get rid of p53 and to stimulate cell proliferation.
But it does that at the DNA level. It's like a DNA binding protein?
No, it actually leads to the degradation of p53. Yes?
So I got a lot of voice. So you mentioned that the HeLa cell line is roughly 60 years old or something like that. And although there are some like xenograft models, a vast majority of our research is based on cell line work. Do you see the scenario of 20 years down the line us having to just chuck a whole bunch of data because it's in such a in vitro, not related to the in vivo characteristics of the solid tumor or whatnot? I mean, how closely do you think they relate to one another?
Well,
I mean, that cell line is 60 years old. That can't possibly be the same disease as it was 60 years ago. John, repeat the question.
Yeah. So the question is, you're dealing with a cell that's been in culture for 60 years and you're doing research with it. Does this have any relevance to clinical cancer today? How can we develop better models to understand human cancer? So I think that this is a very good point. There are a lot of artifacts of putting cells into culture. Let me step back. You cut up 10 tumors and put them into culture. You're lucky if one of them forms a cell line. So first of all, getting a cell out of the body and into a petri dish, it's growing in 100% human serum. It's growing in 1 to 2% oxygen tension. Now you're putting it into 10% or 20% calf serum, and you're giving it 20% oxygen, And it's, and it's normally growing with all kinds of tissues and, enzymes all around it. And now you're giving it a defined media. So there's inherently, even if you create a fresh cell line today, there's something really artificial about it. That being said, if that cell line is addicted to a particular oncogene, a particular cancer gene, for example, the K562 cell came from a patient with chronic myelogenous leukemia, you can screen for drugs that will kill the BCR-ABL enzyme and kill those cells very nicely in that cell line, even though it's quite artificial and it happened decades ago. So you got to just know what you're using the cell line for. It may have an essential characteristic that is maintained from the cancer, even with this artificialness. HeLa cells were from women with HPV-induced cervical cancer. It may not be an inappropriate model to study HPV-associated oncogenesis. So you have to understand the context of this. How do we do better? There's now a move to doing better cell models by growing cells in a three-dimensional manner on matrices. And there are, amongst our colleagues in the PSOC network, there's a group out in California that actually makes different tensile strength matrices and asks how well does the cancer cell grow if it's grown on a floppy matrix or on a stiff matrix. And so actually that's one of the ways that the bioengineers are getting involved with it. So we're constantly struggling with this. The other major advent has been development of mouse models of cancer, where you induce the cancer with human oncogenes in mice and you try to model what's going on there. So I think it is caveat emptor. You have to be a little careful, but if you understand that there's artificialness in any system, it's just Heisenberg's uncertainty. You perturb the system, you have problems, but you have to do it in a context. Yes, another question? Yes, sir.
Is there any relationship for the person who getting the cancer with their career, with their job, especially for the professor and the postdoc?
Could you say that once again?
Is there any relationship for the person who get the cancer, who is easy to get the cancer, with their career, with their job?
With their children?
Job.
Or with their job?
Yeah. Which person who can easily get the cancer?
Yeah, well, I think there are occupational exposures. If you work with radioactivity, we use shields, we wear radiation badges, so, radiation is a hazard. If you're a chemical worker, the chemicals can be a hazard as well. If you're a miner and you're deep in the earth and there's radon all around or there's coal dust all around, there are occupational hazards. Certainly, we have the Occupational Health and Safety Administration in this country, which tries to mitigate some of those concerns, but there are definitely occupational exposures. Being a radiologist, and not, or doing an interventional radiology and, being in front of X-ray machines, that's another hazard too. Yes?
Going back to the cell lines, so you're talking about saying that the cancer cells are immortalized, and are all, well, cell lines by definition are immortalized, are they all cancer cells by definition then? Or do they have some cancer characteristic just because?
So you can create, so Weinberg, who we mentioned earlier, found a way about 10 years ago how to take a normal cell and turn it into a cancer cell. You can actually put 3 or 4 genes into a normal cell and turn it into a cancer cell. Immortalization has to do with an enzyme called telomerase. And telomerase is an enzyme that regenerates the ends of your chromosomes called the telomere. Every time your cell divides, your telomeres get shorter unless telomerase is turned on to re-extend them. And part of that crisis where you have the cells start to crash after several generations in the petri dish is the telomeres start to get too short. Telomerase will repair those things and allow the cells to be immortalized. But an immortalized cell is not necessarily cancer causing. In our cancer biology criteria, the criteria is whether or not you take that cell, inject it into immune deficient mice as a form of tumor. You can take there are many cells out there that will grow forever, but have not accumulated enough genetic changes that they will actually form a tumor. So immortalization is necessary but not sufficient to form a cancer. So there are many cell lines in culture that are very useful for many types of studies that will grow forever but will never form a tumor unless you do something to them.